So we are live in 5, 4, 3, 2, 1. We are live now.
Can't hear you. Janki, you're muted.
Good evening, everyone. Welcome to the platform of Orthopedic Research and Education Foundation India. Today we have our chairman, Dr. John Mukhopadhaya, sir, who is teaching us about high tibial osteotomy. So, over to you, sir.
Okay, good evening, everyone. Today I'm going to talk about high tibial osteotomy, its indications and techniques. And the technique we will be concentrating on will be the open wedge high tibial osteotomy, but I'll talk a little bit about the other techniques as well, okay? Now, what we know about osteoarthritis is that it's a debilitating condition, and it could be for various reasons. You could have normal load on abnormal cartilage, you can have abnormal load on normal cartilage, or you can have abnormal load on abnormal cartilage. We also know that total knee replacements have an excellent result, but you have to bear in mind the age and activity levels. Okay, so the controversies that we need to address are, can we halt or slow the progression of osteoarthritis? And here mechanical and biological factors come in. And what is the best treatment for early disease in a young patient, especially in a young active patient? Okay, now, till recently, we had very little in the literature to show us that malalignment led to progress of osteoarthritis. We had some Scandinavian papers which retrospectively looked at the number of patients with malunions who ended up with malalignment who ended up with total knee replacements. But there are a number of studies now which have really looked at the role of malalignment. The study by Sharma et al. Showed that if you had a varus alignment, the odds on for a radiological progression increased fourfold, and this was directly correlated with the severity of the varus, and this correlated with the radiological progression and the functional decline. So the message was that varus worsens the problem. We also looked at the dynamic loading. This study by Miyazaki et al. Looked at patients who had a varus thrust. That means when you walked, you had this varus thrust gait, and they found that if you had a varus thrust, it actually further increased the progression of the osteoarthritis. Okay, so both these studies fairly conclusively showed that in early osteoarthritis, if you also had malalignment, it significantly increase the progression of the disease. Now, this study by Felsen et al. In JAMA 2013 showed that a frontal plane deformity, which was of more than 3 degrees, led to osteoarthritis and should be corrected. So any deformity greater than 3 degrees would lead to progression of the osteoarthritis and may even lead to osteoarthritis. But then if you look at our patients, they have fairly severe deformities and continue with it till it reaches a stage where you have no other option but to do a total knee replacement. So 4 degrees of deformity increase the risk of osteoarthritis by almost 3 times, and progression was 10 to 20 times faster if there was deformity in osteoarthritis compared to where there was no deformity. Now, high tibial osteotomy has a long history. The recent papers by Jackson et al. From the UK, Gary Epi and Coventry, who really popularized this method in the late 60s, early 70s. Okay, so Coventry was in the US, and these were all closed wedge, lateral closed wedge osteotomies. But however, if you look at history, it dates back to the 19th century, and even Folkman wrote about it in the 19th century. Now, H.T.O became very popular in the 70s after Coventry's sort of articles on it. However, over a period of years, what was seen was that although the initial results were very good, over a period of time, the results diminished. Okay, so in Coventry's own series, where the 5-year results were 87% in terms of good to excellent results. By 10 years, it had come down to 69%. Similarly, Ritter and Feckman had 95% good results at 2 years, but only 58 at 10 years. And Hernigu et al., who did an open wedge osteotomy, this is from France, had an excellent result at 5 years of 90%. That was good to excellent results. But by 10 years, this had come down to 42 or 45%. Now, if you look more carefully at why these results kind of petered out in terms of good and excellent results, there were multiple reasons. So this study by Berman et al. In 1991 looked at 39 osteotomies, out of which 10 had poor results. Now, all the 10 poor results had some problem, almost all of them had some problem with either the pathology, okay, or the technique, okay. So 4 of them had diffuse degenerative arthritis. So we know that this is not a good operation for diffuse degenerative arthritis. 2 of them had inflammatory arthritis, that means rheumatoid or some form of inflammatory arthropathy. 1 had a prior septic arthritis and 1 had a severe post-traumatic deformity. Similarly, if you looked at the surgical technique, this was a study done by Chilag et al. In 1984. They looked at 30 osteotomies with a 51-month follow-up, out of which 43% were satisfactory at this time and 57 were unsatisfactory. Now, out of the 17 poor results, 10 had technical errors. So either there was undercorrection, overcorrection, or joint penetration in 10 of them. And of the 13 good results, all were technically correct. So what it told us is that for the H.T.O. to be successful, you had to pick the right indication. You had to be careful about your patient selection. You had to be clear about the amount of correction you needed and you had to obtain it. The technique was important in terms of soft tissue considerations, etc. And you really need to take all of these into consideration before deciding that your H.T.O. is working or not. So who is the ideal candidate? So the ideal candidate for an H.T.O. is kind of a mythical figure who's thin, active, in the 5th or 6th decade of life, with unicompartmental knee pain, no patella femoral symptoms, a stable knee with full extension and at least 90 degrees of flexion. Now, very rarely do we get an ideal candidate. However, we need to look at what are the contraindications, and there are some absolute contraindications. Now, if the pain is diffuse throughout all 3 compartments of the knee, that's not a good candidate for an osteotomy. Similarly, if they have severe ligamentous laxity, I don't think you should be doing just an osteotomy. You may have to combine it with ligamentous procedures. Now, if you're going to do an H.T.O., which is for a medial compartment osteoarthritis, and the patient has already had a lateral meniscectomy, then when you change the loading to the lateral compartment, you're likely to cause arthritis in the lateral compartment as well. So that would be a contraindication. Similarly, if you had arthrosis in the lateral compartment, inflammatory joint disease, or if the patient had unrealistic expectations, these were all contraindications. Similarly, age greater than 60, range of movement less than 90 degrees, obesity, severe arthrosis, or if there was already tibiofemoral subluxation, one really has to be wary of doing this surgery in these patients. Now, the pre-operative planning is important, and we need to look at the level of deformity, whether it's in the femur or tibia. And I'll show you a case where we go through the steps. You need to look at the joint line, okay? If the joint line is any obliquity or any sort of irregularity of the joint line or step-offs, you need to look at that. You need to look also at the sagittal plane. We tend to only look at the AP plane, but in some cases, if there's a sagittal plane deformity, you also need to do long leg sagittal, that means lateral films, to look at the sagittal plane deformity. And you need to also assess any ligamentous laxity. And all these were brought out clearly by Bailey in his article in OCNA 1994. So the questions that come to us is that, is 5 to 7 years really the end point? What are the inherent limitations? Is TKR after H.T.O. really a problem? Okay, so Now, if you look at more recent studies of H.T.O. And the long-term results, this study by Noddy et al., this was again closing wedge osteotomy. They had a 10 to 22 year follow-up with an 80% survivorship at 10 years. And they found that the best patients were those who were aged, were young, and had at least 120 degrees of flexion. Okay, and if you had significant lateral thrust, or the age was greater than 50 years, or if there was insufficient valgus correction, or you had delayed union or non-union, obviously your results were not going to be that good. Similarly, Sprenger et al. Looked at 76 osteotomies. Again, these were closing wedge osteotomies with internal fixation. And the end point was taken as arthroplasty. And they had a mean follow-up of 10.8 years with a 90% survivorship at 10 years. Okay, similarly, there have been a number of papers from the Asian countries, Korea and Japan, which showing excellent results at over 20 years of follow-up. Okay, and all of them emphasize the precise restoration of the valgus angle. Okay, now what about TKR after H.T.O? Now, Parvizi et al. Published in '86 that if you did a TKR after an H.T.O, there was a high rate of radiographic loosening with high revision rates. Okay, and so this paper became a standard to say that if you did an H.T.O, you had problems if you then had to do a total knee replacement later, which was a natural consequence of the progression of the osteoarthritis. You can slow it down, but you don't completely change the course of the disease. But subsequently, there were other papers by Ritter et al. Who looked at 39 bilateral total knee replacements with an average of 8 years follow-up. Okay, and these were patients who had an H.T.O on one side. Okay, now they found no difference in the knee score, the functional scores, or X-ray findings when you looked at the patient who had the H.T.O on one side or the other side which did not have an H.T.O. So showing that it did not compromise the results. Similarly, Karabatsos et al. In the Canadian Surgical Journal of Surgery looked at 20 patients who had TKR post H.T.O. These were they compared it with 20 bashed primary TKR with a mean follow-up of 5 years. They found that the total knee replacement after H.T.O could be technically challenging, but there really wasn't any statistically significant difference in functional scores. So again, good functional results after of the TKR even after H.T.O. Okay, now what are the problems that one faced with the traditional H.T.O, which was the lateral closing wedge osteotomy? Okay, now you have to look at various things. One is that you took out a chunk of bone. Okay, so your osteotomy took off a chunk of bone. You tended to have a lateral incision, so the scars could be a problem for your later TKR. Because of the osteotomy and the release of the superior tibiofibular joint, which you did in the Coventry, there were scars and adhesions there. And because your osteotomy was not quite in the cora, so the cora in varus deformity with medial compartment osteoarthritis tends to be very close to the knee joint. And when you're doing a lateral closing wedge, your cora is away from that. Okay, so you need to translate if you want to get the mechanical axis right, and this was not very well understood, and therefore you had lateralization of the tibial peg. So here's an example. This is not one of ours. This is from the internet, where you can see lateral closing wedge osteotomy has been done. And now when the patient needs to have a TKR, you can find that the peg of the TKR comes more lateral than it should. Okay, so normally it should be in the middle of the tibia. It comes much more lateral, close to the lateral cortex. The other issues with the closing wedge osteotomies were problems with the peroneal nerve. Now, depending on different series, you had various percentage of complications, as high as 11.9% in Jackson's series. And if you look at EMG, almost 27% had some changes in the EMG. They may not have overt peroneal nerve palsy or a foot drop, but they had changes when you did their EMGs. Okay, the third thing was the kind of a way that one calculated the wedges. Okay, so generally it was taught earlier days that 1 centimeter taken from the lateral side was equal to about a 10-degree correction. Now, this is fine if the width of the proximal tibia is 56 millimeters or 5.6 centimeters. But if the width is more, then you get less correction. If the width is less and you take 1 centimeter, you'll get more correction. So again, it affects the accuracy of your correction if you go by this rule of thumb of 1 centimeter being equal to 10 degrees of correction. So the other methods of osteotomy, we'll just go through some of them. Hernigo popularized the opening wedge osteotomy. This was a study in France. Again, they had excellent results at 10 years. So some of the advantages of that was that you do not need to osteotomize the fibula. The surgical dissection was away from the peroneal nerve, so you had less peroneal nerve problems, but you needed bone graft or allograft. Okay, so you could not open the wedge, and with the methods of fixation that you had and the techniques of the opening wedge osteotomy, you needed to put in bone graft to get secure both stability and secure healing of the osteotomy. So there were other techniques also described. Kudu from Italy talked about the interpositional plate, where you did an open wedge osteotomy, but you put in this plate which had a block of metal which kind of kept the osteotomy apart, and you fix that into the osteotomy so that you stabilized the osteotomy and did not allow it to collapse. And of course, you had the gradual correction using the various external fixator devices. So you could do a corticotomy or osteotomy and then gradually distract and correct and getting bone formation with distraction osteogenesis. So these were the various ways you could do an opening wedge osteotomy. So the other method was the Maquet dome osteotomy. Okay, so Maquet, again, another French surgeon, popularized, although he wasn't the first person who described it, but popularized this method of osteotomy, where your osteotomy was above the tibial tubercle. It was a dome-shaped osteotomy, so you had to either make multiple drill holes or you had to use special curved osteotomes or chisels to do your osteotomy. And then once you got your cut, you could correct the osteotomy. You could use external fixators. Some people used staples, and so here you had a much better range of correction. Okay, we also needed to do a fibula osteotomy. So again, you had the problems of possible peroneal nerve complications. It also allowed you to translate a little bit anteriorly or posteriorly so that you could unload the patellar compartment, although there are some people who feel that that is not really a problem that matters too much. But the advantage was that it allowed you a much better correction. You also, if you use an external fixator, had this ability to adjust it somewhat if you found that your correction was not perfect. And because your osteotomy was above the tibial tubercle, you could tighten the medial collateral ligament without affecting the patellar tendon. However, it had some disadvantages. One was if you used an external fixator, you had pin crack problems. And the second thing was because it was a dome which kind of was centered towards the joint, your cora became at the center of this, okay? So your cora went away from the joint line. So you needed translation. So this is translated medially. Ideally, the distal fragment needed to be translated laterally if you want to maintain exactly the mechanical axis. So Paley came across used this reverse dome osteotomy, again using the Ilizarov, where your dome is so-called the smiling dome, where although it is distal to the tibial tubercle, you have this center cora more close to the joint. Okay, so you need less translation. You still need some translation if you want to maintain the mechanical axis. And you do it with a small incision. You use a pin at the joint and you mark out these holes. So your center of rotation is very close to the joint. And you mark out this osteotomy. Then you sort of complete your osteotomy, use a Ilizarov fixator and correct the deformity. Also, you may need to do a fibula osteotomy if you need more correction. Okay, so we use this method quite a lot. Here's a gentleman in his late 50s who came to us way back in 2001, where we did this. You can see we use this reverse dome osteotomy, and this is a 1-year follow-up, and then he came back at 10 years. Okay, this is in 2011. You can see how nicely the right knee, which we did the osteotomy, was doing, while the left knee, which was pretty okay earlier, had now become severely arthritic and had more varus. Okay, so you can see how much varus is developed in the left knee, which was okay, while his right knee is still nice and straight. And similarly, he had severe pain and also a fixed flexion deformity in the left knee. And he was so happy with the results of the osteotomy on the right side that he insisted we do an osteotomy on the left, although it wasn't really the ideal situation. He more or less forced our hand in doing an osteotomy on the left. So here we used a correction as well as we used the distraction to correct the fixed flexion deformity of the knee. He hasn't come back after this, so hopefully he's still okay, but we can't say for sure. Okay, now what we do today is a H.T.O using an opening wedge osteotomy using lock plates. Okay, so this is an osteotomy. We'll talk about how we do it, where we release the superficial medial collateral ligament, we preserve the pes anserinus tendons, and we do a biplanar osteotomy. So the osteotomy is incomplete in one plane and complete in another plane. And we'll talk about the advantages of that. Okay, so of course you need to do your test for malalignment to see where the deformity is. Okay, so there's your incision. We've released the medial collateral ligament here. So we are at the back of the knee. That's the pes tendon. So your osteotomy is just above the pes tendon. There's the pes anserinus. Here we've released at the back so that, and you put a lever here so that you protect the vascular structures at the back. Okay, and then you do your osteotomy. Make sure you cut through the bone in the posterior cortex. Okay, this is important. Okay, you first mark out this K wire. You put in 2 K wires in the direction you want to do your osteotomy. Okay, and you do your osteotomy just below this wire in the direction of the wire. So initial cutting with the saw, but then the osteotomy is done with these chisels, which are specially designed chisels in 4 different bits or 5 different bits, which you put in one after the other. Okay, and this is where we talk about the biplanar osteotomy, where this transverse osteotomy is not complete. So the lateral cortex is still intact, while this part of the osteotomy, which is the oblique part, which goes above the tibial tuberosity, is complete. So this osteotomy, you go all the way across to the opposite side, while here you gradually go close to the cortex, about 1 centimeter from the cortex, and then gradually distract the medial side with this special distractor that you have. So here's your cut. You can see the vertical cut or oblique cut going this way, and the transverse cut going posteriorly down that way. Okay, so that's the saw. Here the chisels, you can see the chisels being put in one by one. You go up to about 1 centimeter from the lateral cortex. So that's your level that you want to. You don't want to cut right across. You want to keep the lateral cortex intact. And then you have this special instrument which you put in, and you have a screwdriver arrangement here, and you gradually correct the deformity. And this actually gives you a measurement of your correction. Okay. So this will, so you need to do your pre-operative calculations and decide how much you need to correct, and then try to recreate it in surgery. However, you also need to, once you've corrected it, to check your alignment. So once you've got this in, you check your alignment to make sure that your alignment is correct, and you've gone across just to the lateral side. Here we are not looking always for Fujisawa's point, but we want to go across to the lateral side. Once we've got that, we take out, there's a wedge we can insert anteriorly, take out that distraction device, and then put in this laminar spreader in the posterior part so that it gives you room to put your plate in front. And then you put on your plate, and you have some locking spacers here which keeps the plate off the bone so that it protects the sanserinus tendons as it goes across. Okay, so that's your correction. You can see the joint line is maintained, practice goes entirely posteriorly so that the whole medial side is opened adequately. And this is her. You can see how things have gone on to heal well, and she's got a good functional result. So similarly, another case, you can see the medial compartment OA with reduced joint space on this side, varus, but a reasonably good lateral space. Here's the opening wedge osteotomy using this plate. This is her at follow-up, almost a 3-year follow-up, showing excellent results, good alignment, and good function as well. She's able to squat, etc. This is a 58-year-old retired officer who came from another city, and he had been advised total knee replacement, but he didn't want it. He was very active. He wanted to be able to ride his motorcycle, run around, etc. And so we decided to do an H.T.O. We've done a little overcorrection here because the medial side was really bad. And this is him at a 3.5-year follow-up. You can see the left side is absolutely straight, is doing well, but now he's having problem on the right side, which is due for surgery. But because of the pandemic, he was unable to come to Patna to have this surgery. Hopefully he'll come soon for this second side. Hopefully it's not got so bad that we need to do a total knee replacement. Now, sometimes we are forced to do it in older patients. So we said that ideally you want to do it in 50 or maximum 60-year-olds. But there are situations where people don't want knee replacements. This is, this is another younger patient where we did an osteotomy. You can see how the correction again. This is the follow-up, further follow-up, again, excellent results and functions. So you can see that you're able to get consistently good results if you pick the cases right. They should have varus, they should have mainly medial compartmental osteoarthritis, and they should have a good range of motion. Okay, so this is what I was talking about, where we get some patients. This lady is 77, but she did not want a knee replacement, but she was having a lot of problems with walking and pain in the knee. And this is a technique we use for some of these more severe osteoarthritic patients, is that we take off the osteophytes on the medial side as well as in the patella, and we use these osteophytes to put into the defect where we sort of distract. Okay, so this is the correction, and we just put in these osteophytes in with a chopped up, and for some reason this seems to give very quick healing. Okay, we're not sure exactly why it does, whether there's some BMP, etc. in this, but it seems to sort of really get the healing going very quickly. So this is the first side, and 1.5 years later, she came back for the second side. She was so happy with the second, and this is her at about 3.5 years follow-up, doing quite well. Okay, of course, this is not going to last forever because this is in a 77-year-old. She's already 81, and it'll be interesting to see how well she does in the long term. Now, as I said, you need to also check exactly where the deformity is, and it is not always in the tibia. Okay, so this patient had a distal femur fracture, which was fixed earlier, and it went into a bit of varus, but then he also had medial compartment osteoarthritis with varus in the tibia. So here what you need to do is to do your long leg films. You draw your axis. You can see the severe varus. You draw your mechanical line for the femur, and you can just measure your mechanical lateral distal femur angle, and you can see that's way off. And similarly, the medial proximal tibial angle is way off. So you know that you have significant deformity on both sides. And if you just do it in one side, you're going to end up with joint line obliquity problems. Okay. So what we did here was a closing wedge osteotomy of the distal femur and an opening wedge osteotomy of the proximal tibia on the same side at the same sitting. This is the distal femur plate. This is the proximal tibial osteotomy plate. Okay, so we fix them both. Again, now you can see we've got a good correction of the alignment. Now this is him at a year follow-up. You can see he's walking better. And this is him at 3.5 years follow-up. You can see how well he's walking. And now he's having problems on the right side. That was the one which was pretty okay earlier, but is now developing medial compartment osteoarthritis. while the right is doing quite well, even though it was pretty badly arthritic when we did the osteotomy. This goes on to show how by correcting the alignment, you can actually improve the condition of the joint. Of course, there have been studies to even look at arthroscopically at the regeneration of cartilage. It's not hyaline cartilage, but you do get fibrocartilaginous cover of areas which were fairly bare earlier. Okay. So now, of course, everything has complications. You can have major complications such as deep infections, neurovascular injuries, compartment syndrome. Of course, you have to be careful, watchful, then you can reduce the incidence of this. Over and under corrections are technique issues which you have to be careful about. Infection, deep, we mentioned already. You can have superficial infection which are less problematic. You can have some scar problems, neuromas, healing problems, etc. Also, when you're doing your osteotomy, be careful that you don't go across, especially with the medial wedge osteotomy, don't go across to the lateral side because your stability depends on the intact lateral cortex. And also you have to be watchful that fracture lines don't propagate into the joint, okay? So these are two things that you have to be wary of technically when you're doing this. So as a conclusion, what we need to look at is that with the extremely successful results of total knee replacements and the recent revival in interest of the unicondylar knee, one has to consider whether there's still a role for high tibial osteotomy. Okay, so do we really need the high tibial osteotomy? But remember, arthroplasty, total or uni, is not without problems. You require proper training. You need the infrastructure because if you get infections, like this lady had bilateral infections after total knee replacement, which is an absolute disaster. Okay. Also, the social customs here require for you to squat, and with the H.T.O, you do not preclude that. Okay, so most total knee replacements will not allow you to squat. So, in a young, active 40 to 60-year-old, we really need to look at the next 30 to 40 years, and in this age group, no knee is going to last you 30 years. Okay, we have 10-year results, but in the younger patient, by and large, the knees don't seem to last that long. And we have to really look in this subgroup of patients. There are newer techniques to try and preserve cartilage. There are chondroprotective substances. There's oats and things like replantation of cultured chondrocytes. You can do meniscal grafts. You can do cartilage transposition. We talked about oats, etc. But for any of these to succeed, you need to have good alignment. So very often, these come along with a varus. And if you're planning to do any of these joint saving procedures, you also need to correct the alignment. So therefore, H.T.O will have a role. It works. There's a resurgence of interest worldwide. So if you looked at the graph in the 80s to maybe almost 2000, there was a real downslope in the incidence of H.T.O. And now in the last 10 to 15 years, there's again been a resurgence. Much more osteotomies are being done. And there are countries where if you want to do a TKR in a younger patient, you have to actually go through the sort of review board to be allowed to do a TKR. Okay, so opening wedge osteotomy has become gradually the most popular, but it doesn't mean that other methods of osteotomy don't work. You have to decide at which method works for you and master that and do that. Today, we have a number of implants. The locking implants has definitely increased the stability of your fixation, and therefore this allows you to do these corrections without having to use bone graft. And we've done corrections up to 19, 20 degrees without using bone graft. Okay. And the other advantage is you can combine it with other procedures. So you can do a ligamentous reconstruction along with an osteotomy. Okay. You can do chondrocytes or oats, etc., along with an osteotomy. So therefore, there will remain a role for osteotomy. And this is, I think, a technique which is gaining in popularity and certainly something that all of you should be aware of. Thank you.
Thank you so much, sir. I think we have Sadhu sir also in the.
Oh, fantastic.
Yes, sir. So,
good evening, Dr. Sadhu.
Yeah.
How are you doing?
Yeah. Meanwhile, sir, please make us visible, sir. Please keep your video.
Where is Dr. Sadhu?
Yeah, sir. Okay, sir. Please come. Yes, sir. So, yeah, probably some problem with the video.
Okay.
So, just to start with, sir, one question about which is usually commonly asked, that is there is sometimes there is fracture of joint line while doing the osteotomy. So how to avoid that?
The way to avoid it is careful attention to technique. Okay, so make sure you've cut in the right direction. You have your K-wires on the proximal side. Okay, so they protect it to some extent. Okay, and when you're doing, don't go suddenly, go gradually. Make sure you've cut the lateral, the medial cortex, posterior part of the cortex with the saw, and then pass your osteotome slowly, gradually, till you get to that point. Okay, don't stop short. Okay, you need to get to almost 1 centimeter of the lateral cortex. Otherwise, when you try to open that osteotomy, there's a risk of the fracture line propagating into the joint. Similarly, you don't want to go too far to the lateral cortex, then the lateral cortex will snap. So it's important that you maintain that. I think in all the cases we've done so far, we have hardly had, we had 1 or 2 where there's been a suspicion of the lateral cortex, and 1 or 2 where we've been able to pick out the tendency for a fracture line to go into the joint line, and then we put in something like a wire or a screw to prevent that from happening. Okay, so you have to be watchful as you're doing the procedure to prevent this from happening. It's when you suddenly jack it open that you can end up with a problem. Okay.
So there is question asked by Avinash, is that how to decide and check for posterior slope of osteotomy during surgery?
So there are 2 or 3 ways. One is you can put in wires to measure it. Okay. Then you always check your lateral X-ray before you do your fixation. Okay. Or during your fixation, make sure you check the lateral view. Do that before and after. There are some situations where you may want to change the posterior slope. Okay. These are slightly more complicated. If you're trying to address a posterior sort of a PCL or a ACL problem along with your osteotomy, okay, you can change the slope. So by changing the slope, you can reduce the amount of instability. So like posteriorly, if you want it not to go posteriorly, you increase the slope. Or if you want it not to go anteriorly, you can reduce the slope.
So while doing the osteotomy, there is a chance of increasing posterior slope, right, sir, for open wedge medial?
So there is a chance of this, and that happens if you haven't cut the posterior cortex adequately. Okay. So then when you distract, the front tends to distract more and the back doesn't distract. So it's important to make sure that you've cut through the posterior cortex cleanly. And to do that, you need to make sure that you elevated the medial collateral ligament adequately, released it adequately, so that you can put your levers safely at the back of the knee when you do your cut with the saw. Okay, so that's important technically.
So another question from Avinash is how successful if we use external fixator in place of Tomofix plates?
So fine. External fixators are good. They're not bad. Okay. The advantage of the external fixator, the big advantage is if for some reason your correction is either over or under, you have the ability to adjust your correction. Okay, so that's the big advantage. The disadvantage is patients don't particularly like an external fixator. You have the risk of pin track problems. And the third thing is, when do you take it off? Because patients are always in a hurry to take it off. And if you, for some reason, you get delayed healing, then you are stuck into this position, when do I take it off? So otherwise, you do it technically right, everything works well. It's a very good way, in fact. It's not a bad way. we still use it sometimes for larger corrections. I think sometimes something like a Ilizarov or even an external sort of external fixator can be used successfully. You can use gradual or acute correction even using the external fixator. So when we do a reverse dome, we tend to do an acute correction. If you're doing an opening wedge, we tend to do a gradual correction. Okay.
So, in few books, sir, it is written that in obese patient, H.T.O is relatively contraindicated. So, sir, what is means till what BMI we can do this one?
So one of the contraindications is if the body weight is more than 50% more than the expected body weight at that age. Okay.
Okay.
So, but personally, what do you do for them? Your other option is a TKR, which again is a problem in an overweight person. Okay. So in the younger patient, you will try your best to get them to reduce weight. But again, if the knees are a problem, they cannot exercise adequately. So we still do it even in obese patients, but of course you have to watch out that your results are not going to be as good.
So in few of the osteoarthritis cases, actually medial joint osteoarthritis, there may be some laxity of the lateral ligamentous structure. So do we need to do something for that, or if we are doing them, in which cases?
So I think a lot of it is a false laxity, okay? Because the medial compartment has got worn out a bit, it tends to open when you give varus. Huh?
Yes.
But it's not opening, it's the collapse on the medial side rather than an opening on the lateral side. Okay, so you need to examine the patient carefully, because when you're walking, you're getting a lateral thrust, which makes you think that the lateral collateral ligament is getting stretched out. Usually, once you correct it, this corrects itself. But if you have a definite laxity, then you need to try and tighten the lateral collateral ligament. And you can't do that using the opening wedge osteotomy. You have to do that. There are different ways. You can do an osteotomy and pull down the proximal tibia. That's one way. Usually, it's not a problem in the so-called type group of patients that we are doing a H.T.O for osteoarthritis. Is more of a problem in the post-traumatic patient, where you might have to think of a ligamentous reconstruction or something like that if there's a definite ligamentous injury. Okay, and we've had a couple where we've had to do that.
So we have one question by Dr. Subhansu, is that when to mobilize patient partial or full weight bearing after H.T.O, and each mobilization depends on age.
Okay, so I think as long as you technically have not had a problem during surgery, we tend to mobilize them partial weight bearing straight away. Okay, toe touch initially, then weight bearing as tolerated. And by 4 to 6 weeks, we find them coming to the OPD without the walker. Huh? So usually full weight bearing by 6 weeks.
So another question.
So the advantage of this locking plate is that it's very stable, and because it's a biplanar osteotomy, the front part of it is in contact. So it heals very quickly. And because the lateral cortex is intact, when you have this plate on the medial side, it's a very stable situation. So actually you can fully weight bear them also. We are a bit hesitant to do that, but we certainly start partial weight bearing straight away.
So I have not seen using a bone graft by you in when you are applying a Tomofix. So sir, in any case, even in the past, do you have used?
So earlier using conventional plates, we always used bone graft. Still for some of the post-traumatic osteoarthritis, we still use bone graft because we're doing other things along with the correction, or sometimes it's an intra-articular correction, etc. So there we want something to support the correction, okay? But so far we've done, that's what I'm saying, so far in more than 100 cases, we've not used bone graft. in any of our opening wedge H.T.Os for osteoarthritis, medial compartment osteoarthritis.
So one question from Dr. Neeraj Raj is that among the described techniques like lateral closed wedge technique, medial open wedge technique, and focal dome osteotomy, which one is better?
So it's, I personally think the medial wedge, opening wedge is good because it gives you, you don't lose any bone. Okay. When you're doing a lateral closing wedge, you're losing some bone. Okay. So plus you don't have problems with the peroneal nerve, and you don't have to worry about a fibula osteotomy in most of these. Okay. So I think this is an excellent technique. Will this remain the best technique forever? I don't know, because there'll always be something else that comes up. Okay. So personally, because you're not changing the axis, your cora is close to the joint because you're doing an oblique osteotomy. So your cora opening wedge, so your cora is very close to the joint. It's a centimeter from the joint. Okay. So you do not need to do any significant translation. Okay. So those are the advantages of it. Having said that, the Japanese do the closing wedge osteotomy and they have shown excellent 15 to 20 year results with that. So I can't say that that is a bad method or something like that. But personally, I feel that, and this is a method which is becoming increasingly popular throughout the world.
So one question from Dr. Sachin is that which kind of graft used in H.T.O, cortical or cancellous? Does it use only for support of the construct? I think this.
So we don't use graft. If we were going to use graft, we would use cortico-cancellous graft from the iliac crest. Okay, the strut on the medial to support the medial side.
So in your lecture, sir, you have shown us that smiley osteotomy. In that case, sir, is it the cora is a little far from what we have used the dome?
No, so the dome is, the Maquet dome is convex towards the joint.
Yes.
Okay, so the center of that is away from the joint. You understand? So if you draw a circle, where is the center? Okay, when it's a reverse dome or a smiling dome, then it is, the convexity is away from the joint. So the
center
is closer to the joint. Okay, in fact, we draw it with a pin in the, almost in the joint line. So it's very close to the joint line.
So, yes. So one basic question regarding the scanogram or radiological evaluation. So what we have to check in that sense in a scanogram, and how the ideal scanogram we can take?
I think all that is there in the books and this thing. It's usually done at a distance of 10 meters. You use 51-inch plate. Nowadays, with the newer techniques, you can do stitching of the images, but originally you needed a 51-inch cassette. Okay. You need to keep the patella facing forwards in most situations, unless it's subluxated. Otherwise, the deformity gets kind of hidden, because the patients tend to externally rotate their legs, and then the deformity, especially valgus, can get hidden by that. Okay. And a distance of 10 feet, I think, from the X-ray tube.
So one question from Dr. Subhansu is that in H.T.O2, we have to be in valgus some degree.
So if we did the traditional lateral closing wedge osteotomy, okay, so there was something known as the Fujisawa point. Okay. Yeah, which is about 1/3 of the way from the eminence to the lateral cortex.
Yes.
So depending on how bad the osteoarthritis was, if it was bone on bone, then they wanted you to go all the way to Fujisawa point, which was an overcorrection. Okay. Now with the medial opening wedge, we tend to correct it to just across the tibial spine. We don't go for Fujisawa point. So then you get valgus, and then it doesn't look so great.
So one doubt about during the surgical technique, how to save MCL, sir? Because although you have shown in the diagram.
So it's the superficial. In fact, you don't even, if you, like Professor Lobenhofer was here in Delhi for the osteotomy course some years ago, they actually sacrifice the superficial collateral ligament. They release it completely. Because the superficial part at the back, you can release, but you keep the deep intact. But we tend to just release it off the bone to give us enough space. We don't cut it across, okay? Because by relaxing the collateral ligament, your osteotomy is kind of distal to the deep collateral, okay? So it releases, makes it easier to do the correction. Okay, but we tend to release it without actually cutting it. But if it gets divided a bit, we don't mind that. We're not bothered about that. As long as you keep the deep part of the middle collateral ligament intact.
So, we have seen you doing the H.T.O with ACL reconstruction. So how the technique differs in that case?
So it differs in that your anterior screw in the plate may be difficult to put in, okay? The top screw, anterior one, may come in the way of your graft placement, okay? So you have to be careful about that. So you may have to avoid putting that one screw. Other option is to do something like a Pudu plate where it doesn't matter so much.
And so, in your experience, sir, what is the maximum follow-up you have in your?
So I told you, we've got more than a 10-year follow-up on those patients. We've got 5-6 year follow-ups with the open wedge osteotomy, which we started doing about 12-13 years ago. We've not had to, so there are two ways of looking at follow-up. One is actual patient coming and you checking them out. The other is that when they come back with problems. Okay. So very few of them have had to come back and then have a TKR. Can't think. I know one has a problem because she had ligamentous instability and we still went ahead and did the osteotomy and she's still unstable and she's going to need a TKR. But other than that, very few patients who've had to come back and have a TKR for such a long time. Okay. So
one question from Dr. Neeraj Raj. We want to know about the unicompartmental TKR. Is it superior to H.T.O in treating unicompartmental osteoarthritis?
So that depends on who you talk to. Huh?
Yes.
If you talk to an arthroplasty surgeon, he'll say definitely it's better. Is Dr. Sadhu there? He could answer that.
Sir, probably, sir, voice was not there. So, yeah.
Okay. But okay, yes. So let's put it this way. It depends on the pathology. Okay. If you have an elderly lady with medial compartment osteoarthritis, I think that is with osteoporotic bone, that is ideal for a unicompartmental knee. Okay. If you have a young patient who's active, who wants to continue sporting activity, has a varus, then definitely it's not right for a unicondylar knee. You want to do an H.T.O. Okay. So I think it's, as they say, horses for courses. Okay. You need to select your patient both in terms of what the expectations are and the activity levels and the quality of bone. Okay. So if they're very poor quality bone, there's no point doing an H.T.O.
So one
collapse. Okay. When you try to distract it, the thing is going to just walk through the bone.
So one common question by the patient they used to ask while before considering of H.T.O, sir, that do we have a problem in the TKR if they will get, although you have explained this one. So in your experience, sir, if you have done, do you have?
So I think, see, one is the implant.
Yeah.
Okay. You may have problems removing the implant if they come back after a long time. That is something you have to be aware of. Although the 4.5, 5.5 ones are a little less problematic than the 3.5 locking screws. But because of titanium, there is still some theoretical risk of problems in implant removal. Okay. So that is one thing. The second thing is your incision. And since we do almost like a midline, just a slightly medial parapatellar incision, I don't think that is a problem. Okay. Otherwise, because we are not cutting off bone, etc., I don't expect it to be a big problem. Of course, if you have any implant-related infection, then it's a problem.
So one very rare case of if there is diaphyseal deformity, like the cora is in the diaphysis. Usually it is in the metaphysis or near the joint. So in those cases also, sir, is it work?
So I think you have to understand that you need to correct the deformity close to where the deformity is, or at the deformity. Okay?
Or with the translation.
You can't do a correction at the knee level if it's a diaphyseal deformity. Okay? Sometimes you may have to do it a bit away because of the skin conditions or something like that, but then you will need to translate to maintain the mechanical axis. Okay. Whenever the cora is away from where you're doing the osteotomy, you're going to need to translate to get the mechanical axis correct. So certainly for the diaphysis, you won't do it in the at the joint level or below. You may do it a little away from exactly where the deformity is because of skin conditions or bone. Okay.
Yeah. Thank you so much, sir. I think most of the questions we have taken from.
Till next week.
Yeah. And next week,
Next
sir,
week
we have
Dr. Sadhu. Yeah.
Yes, sir. For the salvage of neck of femur fracture in young. The topic.
Sure. Okay.
Thank you so much, sir. It was great.